just come back from the States, did a couple of, and one of the things that I've got since I've started this journey, I've started to become really good friends with people like David Covington and stuff. So I've actually found the Americans are great. You know, they just send you a plane ticket and say, come across here, boy, and drink some booze and stuff. And that's the way they deal with mental health, it seems. But one of the things I've really cottoned on to, and a few of you quick ones might have seen the Crisis Now document. You can actually go to crisisnow.com. Is a kind of movement that's starting to build over there. And I know David's talking to a conference in New Orleans next week, 6,000 hospital administrators and clinicians around mental health, around just where the stuff's leading. And I just wanted to quickly go through it, just to give you a feel for some of the stuff I saw. Okay, and the general view is that they feel they're in hospitals, they're outnumbered, overwhelmed, ill-equipped and struggling for resources. And EDs in New Zealand told me the same stuff. And they kind of losing the battle of mental health access and care. This came out a little while ago. 8 in 10 ED doctors in the States, and there's 32,000 in the sample, say mental health systems is not working for their patients. Okay, this one was Cherie Krugenberg. She represents 400 hospitals over there, and I think her statement's pretty obvious. And this actually has gone to the Presidential Committee that's currently looking at mental health there. The increasing dependence on hospital EDs to provide behavioural evaluation treatment is not appropriate, not safe, not efficient use of dwindling community emergency resources. They just can't do it. It impacts the patient's families, other patients and their families, and of course the hospital staff. And they're struggling with the same stuff as we are, and they're struggling with the money stuff. Okay. Good crisis care is supposed to actually reduce suicides and provide more immediate and targeted help for the people. And if we can actually do it early, we can actually cut the cost. And that's a key driver in the dialogue that's happening in the States. Okay, because you remember their stuff's often done around insurance. Okay, and with the changes to Obamacare that are likely, even though that's stalled at the moment, there's a whole lot of opportunities to, I think, radically relook at how we do crisis care. They had a crisis services task force. This was actually under Obama's time, and pretty much they identified the 4 key things that you need to happen if you're going to have a good crisis response thing. It's a regional statewide crisis call centres coordinating in real time, and I've actually seen it, and I've sat in a police car, and I can see on an iPad on the police cars, the patrol cars dashboard, where there are beds they can take people to in that city now. Real time, 24/7. So we're seeing law enforcement, and let's be honest, law enforcement has in many places become the de facto mental health support worker untrained. Centrally deployed 24/7 mobile teams. When I saw this in Phoenix, it kind of made me laugh. You know, they talked about it being very much low-key, unmarked vehicle, and yet I jumped in the back of one of those giant blacked out window SUVs with mags the size of a football field and about a 6-litre V8, and they call that a discreet vehicle. Okay, but interestingly enough, when police see something in the community and call to it, they're actually backing off, so they don't actually have the flashing lights in the cop car there. They're actually having a discrete vehicle with peer-led services in it, with access to clinical backup on call, and in some places they actually have that clinical person available. Short-term subacute residential crisis stabilisation programs, and these are not in hospitals. These are in community, and essential crisis care principles and practices. The regional statewide crisis call centres, they're using some fantastic technology, and the argument has been very much about it being the equivalent of air traffic control. You know, Joe said this morning, when you jump on a plane, we've got an expectation that million bolts, nuts and bolts that are flying up in the air is going to bring you safely down the other end. And we monitor it. Okay, and they're talking about systems over there that are going to kind of head that same way. And to the point that when the shootings were happening in Las Vegas, they were monitoring social media, I guess the temperature of social media in Nevada and the southern states, and then using targeted messaging to build community calmness. Okay, that's big brother thinking, isn't it?
Yes.
It's bloody scary shit, I thought, but I can't tell you if it works or not, because they're in a very early day of dipping the toe in the water of this sort of stuff. But ironically, the Facebooks and that aren't turned off. Because, you know, no one gets excited about 58 people dying in a concert. Okay, and we don't want more to die. So it's an interesting development and things we just kind of need to think of. The centrally deployed teams, I talked a bit about those. And it's interesting that often the police now are actually withdrawing right down out of the street. So they're there on call, but they don't actually want to be immediately there because it doesn't allow you to de-escalate well. The residential crisis programs, I'll show you a little bit about this, but it's subacute and they take everyone. And the one I saw in Peoria that I spent a bit of time in Arizona, it basically has about 85% of its people are bought by law enforcement. Of those, at least 80% of them are A&D. Okay, but they take everyone. And the police don't take people to ED now. They're moving away from that. ED is where you take people who've got a gunshot wound. Okay, and the interesting thing, about a third of the cost, and I'll be able to show you some evidence metrics in a minute. Here's the essential principles and practices they're using. So it's got to have a recovery orientation, trauma-informed care, significant use of peer staff, strong commitments to safety and collaboration with law enforcement. Some of these things are actually being funded by law enforcement. It's not out of health. Because the police, it's their problem at the moment. And they just found the health thing too dynamically difficult to deal with in some states. I'll just put this wee video on, so it'll actually give you a bit of a view what it's like. It's quite short, but if you just tell me if it's not your thing.
Mental health crisis care in the U.S. is in distress. The number of people who are dying of suicide, the struggle of individuals in emergency departments, people going to jail because better crisis care is not available. And a group of us put together the Crisis Now document to highlight that effective strategies are not only possible, but being performed today here in Arizona. 3 key services: an air traffic control call center that navigates and focuses on the person till they get what they need. Community-based mobile crisis that doesn't require someone to go to the hospital, but meets them where they are, on the street, at their apartment. And if they need it, a crisis facility they can go to that will see them right now. Law enforcement can bring them there and go back and do their job. Those are 3 simple things, but they make all the difference in mental health crisis care being effective, inexpensive, and safe for a community.
We really are a team with law enforcement, with emergency response, with the providers of behavioral health. It takes more than just a call center to answer the phone and tell somebody else to go do something. We do our absolute best to take care of people who need us the most.
We're dispatching approximately 50 to 75 calls daily to the 8 counties that we provide services for here in Southern Arizona. The crisis mobile team is so fortunate to have the modern technology that we have now. We have a system called Adopt that has a GPS that is able to pick up on the phones and is able to send the activations to our crisis mobile teams that are on hand that are going to be on in the community For example, if somebody's in crisis and they're in Yuma County, I'm able to look at the dots and find out which one of the 5 Yuma teams I have available is geographically closer to the member in crisis.
Once we activate a mobile team out to the member, more often than not, they will call us back to schedule an intake appointment. Looking at the numbers through September 30th, we've actually scheduled a total of a little over 4,500 appointments. Out of those, 3,500 were intake appointments. It's a great collaboration that we have with our providers here in Southern Arizona to make sure that our members are set up with those services.
The purpose of the call center is not simply to take calls and route them, or take calls and manage the issue or the challenge at hand, but is to serve as a comprehensive management of the situation and delivery and connecting point for individuals through warm handoffs and transfers between whatever network of service providers there are in the community. And the underlying element that makes it so intelligent is robust data systems, infrastructure, and being able to move data and information fluidly between various providers and various community stakeholders to effectively manage individuals' input, throughput, and output within the crisis system continuum. There's no doubt and no question in my mind that the effectiveness and the efficiency of this process, one, provides the best care possible to the individual in the most dignified and honorable way. It's going to be the most cost-effective process for the taxpayer base and the healthcare industry, and that as professionals that we can go home at night ethically viewing that we've done the best we can in the right way.
And mobile crisis is an integral part of the crisis system within the state of Arizona. It comprises 2 team members. One is a master's level clinician, one is a bachelor's level person or a behavioral health technician. When law enforcement shows up to an individual's home who's in crisis, they have their lights on, it's very obvious that they're there, and it can be embarrassing and it can be traumatic for the person who's in crisis. But when mobile crisis shows up, they come 2 people that get out of an unmarked van. It just looks like 2 old friends that are coming to have a visit. And they're able to identify people that can help them, that can provide that support to them to help keep them safe. It doesn't matter where we do interventions, it's less costly and it's more effective because it's right to the person who's in need.
The emergency room is pretty much the worst place for a person who has a psychiatric need. I used to work in a level 1 trauma center, and I would do psych consults in the ER. And I would be sitting there trying to do an interview with someone who was depressed and suicidal as they were wheeling gunshot victims behind me, screaming and bloody. The best thing is to get them out of that environment where they can be surrounded by people who are trained in behavioral health, trained in de-escalation, can give them the space that they need and the support that they need and a little more time rather than this push to get them out because they don't really belong there. We have to be easier to access than jail because cops are busy. They didn't get into being a policeman, woman, to be a social worker. They just need a place to bring people and then they can go on about their business and free up their time to be doing what it is that they're best at doing. Half of our volume comes via law enforcement. We've had up to 7 cop cars back there. We take them one after another, and when we do that, we bring extra staff up into our Sallyport area because we want to get them in and out as quick as possible.
But once we hit the facility, you're talking 3 minutes where the officer is dropping off the patient and getting those resources to the individual. If you look at what's happening across the country, you know, when in relations to officer-involved shootings, a lot of that has to do with how the officers are interacting with individuals that are in crisis. We have to be better educated. We have to have those skills to understand and recognize mental illness and how to deal with that. So the most important thing that mental health providers and law enforcement can do is continue that partnership to work out issues, to make the whole system more efficient. And it has made us more educated in the field of mental illness. I believe we've made mental health providers more educated in the policing side of it. We're serving our community and you have to do it together.
So when we free up an officer's time, they're back on the street, they're back in their car, they're answering calls, they're not sitting at an emergency room. That's our purpose. That's why we work with law enforcement. I've trained all of my staff and then they've trained their staff, and it's been our culture for the last 20 years. Never, ever, never, ever refuse services for law enforcement or any first responder. That's what we're there for. We are the safety net for the safety net. And we will never tell an officer to go somewhere else. It's hard for me to even think about not accepting a person that a law enforcement officer brings to us. We are the responsible agency in the community.
The state of Arizona crisis system is an exemplary model of how crisis systems could be delivered. There has been a look both at the clinical models, what does it really take clinically to intervene, to do engagement skills, to serve people, but there really is also all these business aspects, and it's the two coming together, having the technology, having the analytics, thinking through the different business structures that an organization can have. Bringing both that and the clinical together is what really makes a difference in delivering care and having the cost savings and the outcomes that we so desperately need.
Crisis now is a different approach, and it's been fueled, it's been inspired by our successes in Arizona. If we can do that here, it can be done anywhere.
Now, that does feel a little bit like a sales tool, okay? And hey, I get that totally. And actually kind of think that that's kind of just the American way. But this is what you saw in that video was Tucson, 2 million people. Okay, this is Phoenix, 4 million people. So about the same as New Zealand. And according to Aetna and Mercy Maricopa, who are the funders? They are the insurers. These were the results of taking that approach. Okay, law enforcement engaged 22,000, transferred directly to crisis facilities without visiting ED. They didn't go to ED at all, didn't go to anywhere near a hospital. The crisis clinical fit to need improved 6 times. So they're actually getting the right treatment at the right place, at the right way, in the right time, better. They saved EDs in that area, 37 million. Okay, and avoided costs. So EDs that weren't unhappy about that. One of the big issues with the EDs over there is that most of them were facing a significant, unless they could cut their numbers, they were all facing large capex expenditure on growing building and stuff. So that isn't even included in that 37 million. That would have been hundreds of millions of dollars worth of extensions to hospitals. Okay. Reduced total psychiatric boarding by 45 years. They gave me one of those sort of graphs that would be what Steve Duffy would understand, or I just didn't understand it. That I just had to take their word for it. PricewaterhouseCoopers checked it, so a big accountant with slightly dodgy ways. I'm sure they were overselling it a little bit, but you've got to say that's a lot of saving. Reduced potential inpatient spend by $260 million. Okay, 1 year. What's DHB's budget a year? Is that your budget? Would you get that much? So if you could actually save a whole DHB's budget, why wouldn't we do it? And improve services at the same time? And save the equivalent of 37 full-time equivalent police officers. Okay.
So is the psychiatric ward, is that inpatient?
Yes. So, as you can imagine, it's not difficult getting police officers interested in this conversation. And we're currently talking to New Zealand Police about it.
What about the ones that don't come, that they are not arrested by police? They are acutely unwell. Are they allowed still to go to ED?
Yeah, about 15% of the people that walked into Parori were either brought in by family, loved ones, or self-referrals. Not many self-referrals, to be honest. And in that particular place, it was slightly different in that they had a crisis centre thing. Then right alongside it, they had a subacute. And then at a different part of the property, they actually had a respite care service as well. So it was like a continuum of services people could access.
They say law enforcement, these people don't have a choice, to go in that facility. They could say on the door, bug off, I don't want to go.
I think
law enforcement, it's police say you need to stay there 3 days. I don't know.
Hey, I can't tell you that. When I was looking in Atlanta, there was at least 3 police forces in Atlanta at work using the same system, and none of them used the same interruptive systems because they were always competing. But the state police didn't agree with one part of Atlanta City on software and stuff like that. So there was still some, I think, bickering and fighting going on there, and that's just politics of big entities. But this gives you an indication of where it's going. I'm not saying it is the be all and end all, but I do love the fact it's peer led. Okay, and most of the services are.
Did he say two peer workers, one at a master's level and one at a BA level? Is that what he was saying?
Well, I can tell you it wasn't when I went into the car, because one of the guys looked like he'd fallen off the back of a Harley Davidson, had more tattoos than you both think. But people at McDonald's have MAs over there. Okay, so, yeah.
They said two clinical workers, one of them.
Well, in Phoenix it was actually peer led. Okay, but there was a peer led one with a nurse as well, in one of them, and I think it depends what they're called out to. Okay, because they had 4 mobile units in the city. Okay, this is when you get this sent to you, you'll see how they've sort of structured it. So this is giving a little bit more data to it. And if you want to know a little bit more about it, I can share a lot of that stuff. We're currently talking with people now about it in DHBs in New Zealand.